Well, hello, everyone. Good evening. Welcome to this episode of Scoliosis Dialogues, the SRS podcast, where we take a deep dive into the latest and most impactful research in scoliosis. I'm your host, Byron Stephens, and tonight we have two incredibly distinguished guests to join us. First, we have Dr. Stephen Glassman, who's medical director of the Norton Leatherman Spine Center, past president of the Scoliosis Research Society. Dr. Glassman has authored hundreds of landmark papers in adult spinal deformity with major contributions to our field. And joining us as well is Dr. Michael Kelly, professor of orthopedic surgery and director of scoliosis and spinal deformities at the Division of Orthopedics and Scoliosis at Rady Children's Hospital in San Diego. Welcome, Dr. Kelly and Dr. Glassman. It's an honor to have you here tonight.
Good to see you.
Good to be here.
So tonight we're going to focus on a major new paper that you were both involved with that was just published in JAMA Surgery titled Operative versus Non-Operative Treatment for Adult Symptomatic Lumbar Scoliosis at 8-Year Follow-Up. So this is I'll give a brief overview and then we'll kind of dive into your thoughts and go over some questions if that's all right. The study is a prospective multi-center clinical trial that enrolled 286 patients aged 40 to 80 years across 9 North American centers. And patients either received operative treatment or non-operative care like physical therapy, medications, and injections. Due to the pragmatic trial design, significant crossover between the groups, the authors used an as-treated analysis to better reflect the real-world decision-making, much like the sport trial from several decades ago. The results demonstrated incredible durability of surgical treatment, with at 8 years, surgical patients demonstrating a significant 14.29 point greater improvement in Oswestry Disability Index and a 0.74 point greater improvement in SRS 22 scores compared to non-operative treatment, both of which were statistically and clinically significant. Importantly, the benefits of surgery remain durable over time with almost no evidence of decline from the study's 2-year and 5-year results. Serious adverse events related to surgery were relatively common, about 22 per 100 person years in the first 2 years. But even in patients with complications, they still showed better outcomes than those managed non-operatively. So I think this study clearly delivers one of the strongest pieces of long-term evidence to date that operative treatment for symptomatic adult scoliosis provides durable, meaningful improvements for many patients. And I really want to open it up to some questions for you guys now and to get your thoughts on the study further. Mike, I know you had a front row seat to the origin story, so to speak, of this trial. Would you care to start us off with a story or two about how ASLS1 got started with Dr. Keith Bridwell?
Yeah, that's actually a perfect intro. And I think Dr. Glassman would know a lot better than me about the origin story. But Dr. Bridwell really leveraged the experience of the spinal deformity study group and the high volume, reliable participating surgeons to find a group to get NIH funding to do and Dr. Bridwell hears this, he won't like how I phrase it, but to do a comparative effectiveness study, really, with a randomized cohort to try and investigate whether or not surgery is superior to non-operative care. And this was designed right around the time that Weinstein's sport papers were published. So naturally, they had a randomized and observational cohort group that eventually was funded by the NIH. I'm pretty sure they went through at least one round of revisions, resubmissions with the NIH. And as you discussed, I think it's important now to note that it's really become a durability study. And it was not actually, I think appropriate interpretation of the study requires pragmatic interpretation, but it was not truly a pragmatic study design, which I think is probably the most appropriate for interventions like this, especially when we're trying to compare them to non-operative care in the United States, where people, when they come to the surgeon, they're not here to, they don't come to us to get non-operative care. Byron, I don't know if you saw it, but the New England Journal recently published a study, a randomized study of total hip versus non-operative care for hip osteoarthritis, showing that total hips are superior than non-operative care with 6 whole months of follow-up. And the ASLS study required 2 years of follow-up, which ultimately doomed the study to, I should say, publication in JBJS rather than the New England Journal of Medicine, because a study of effectiveness for adult symptomatic lumbar scoliosis should probably go to the point at which recovery has plateaued, which I think most of us for adult scoliosis would agree occurs right around 12 months. And even though there was a large amount of crossover at 12 months, the effect size was still so big at 12 months that the crossover was negated and surgery was still superior in intention to treat analysis. And it was really the loss of non-operative patients over the following year that overwhelmed the effect size. And after that, all subsequent studies have been as treated and studying the durability and showing what realistically, what really the spinal deformity study group showed and what the ISSG has shown, but with just a little bit tighter methodology and keeping good follow-up.
Great. Dr. Glassman?
So I want to go back a little bit to the beginning as well. And I just want to recognize, first of all, how hard it is to do an RCT. Anyone who's been involved in it, it is an ungodly amount of dedication and work. And I think all of us who lived through this had times when we thought Keith was like Pharaoh and, driving us to build the pyramids, and Michael probably more than anyone. But I think you can't minimize the credit he deserves for making this happen. It would have been so easy to fall off and, give up on the design and give up on working through this. And it's just a tremendous credit that he pulled and pushed everyone through that. I think also a lot of credit to Michael, who wrote the original paper. That was a tremendous amount of work bringing together what was a really complex data set, because it was intended to be an RCT, but there was tremendous crossover. And Michael just explained some of why that created problems in data analysis. But he did a fantastic job of taking that data and making it understandable to people, so that it was, at the time, at 2 years, certainly the best study in adult scoliosis I think that had ever really been done. And then to Justin Smith, who did a similarly great job with the 5 and 8 year data. So I think it's important to recognize that to start with. There were a lot of people involved who work hard, but those, 3 people really brought this to fruition. I think that it showed a lot of what we thought and some things we didn't think, right? So in general, the sort of mantra before the study was that surgical patients got better, non-surgical patients got worse. Patients treated non-operatively, and that's not actually what the data showed. It showed that non-operative patients stayed about the same. They maybe even got a little bit better, which actually made it harder to show the benefit of the surgery. But the surgery was good enough that you saw the benefit of it without the sort of model data. Some of it was mined previously that suggested that non-operative patients would get worse, which would make it easier to show benefit in the operative patients. So I think we showed that in Michael's first paper. And then what this latest paper showed was that held up, essentially. The non-operative patients, they didn't fall off a lot more. They sort of stayed where they were. And the surgical patients stayed where they were. They maintained the benefit that we had given them. So it, sort of re-emphasized the message that Michael had in the first paper, which was, if you can live with your scoliosis, you don't need to have surgery. You're not likely to get worse and be terrible, so you have to do something prophylactically. You're likely to still be able to, stay where you are. But if your symptoms were intolerable, that the surgery really was a useful intervention in improving that. That's sort of how I look at it. And Michael's right. What this showed was the durability of that benefit. I don't know, Michael, I think that's a fair description.
Yeah. Yeah. Great.
I think too, the other piece of work that I would highlight at this point would be the complications associated with non-operative treatment, right? And that's one of the, I believe it was a paper that came out of this work as well at some point, right, Mike? There are significant adverse events, whether it's GI bleeds associated with long-term NSAID use, and there is some downside other than opportunity cost of not doing surgery.
Yeah, and Justin and Chris Shaffrey sort of spearheaded the one about just mounting comorbidities and this idea of multimorbidity in this aging population, that, whether or not the SRS is truly specific, I think that those, the debilitating function from bad hips and bad knees and other musculoskeletal disease start to bleed over, and they certainly affect the proms.
I think one of the interesting things that the data has shown as well, and you can see it in some of the cost analyses that were done alongside this data, is that even patients who had a revision, one, maybe two, still maintained a fair amount of benefit, right? Because one of the things we worry about is a fair number of people get an adjacent level problem or something and get some additional surgery. And I think there was certainly for a while a thought that if you need another surgery, that's sort of a death knell, and your procedure then wasn't worthwhile. And I think this data shows that not to be true. That patients, especially with a single revision, still ended up being pretty good, better than the non-op cohort. I think that was sort of an interesting observation. Obviously, the more you can get rid of those complications, the better your cohort will be. I think the complication side of it is, as Michael was alluding to, right? We use PROMS as our outcome measure, and complications aren't necessarily well reflected in PROMS. As an example, right? If you have a neurologic deficit and you have disability, that's well reflected in your PROMS. But if you have a heart attack, right? A year later, your PROMS may look perfectly fine. You've recovered, you feel fine, and you report as if there really isn't any deterioration. But if you look at, for example, your ASA classification or your Charlson Comorbidity Index, or, in essence, your risk for the next thing you need, whether it's a spine surgery or not, you're at way higher risk. If you've had a heart attack, your chances of dying from the next surgery is clearly greater, right? So although it's not well reflected in PROMS, I think it's important that we don't underestimate the importance of those complications.
Great. What, from a patient perspective, what would you say that work like this does to your confidence in counseling patients in the clinic? So if you have a patient or family member who's struggling with a decision about whether or not to pursue surgery in light of the risks, how does this data affect your informed decision-making process with your patients?
Michael, you want to?
Yeah, I would say that's like a perfectly timely question based upon the last call Justin and I had with Dr. Bridwell, where you have not had the pleasure of trying to write a paper with me, Byron, where I am really I am not that interested in means and things like that anymore. And I want to know what it means for each individual patient as we move towards a precision and personalized medicine program. And we don't have that yet. We can, and Keith, while I was thinking that, Keith said, well, I just want means. He just wanted to see the averages. And that's how you do from an epidemiologic level and a mile high view. That's how you do a comparative effectiveness study. But I think Jacob Greenberg's, I call it the cauda equina graph, where he has every single patient's individual trajectory and then the average of any patient's experience in ASLS. We see that on average, surgery will help you. And that on average, if you have a complication that requires repeat surgery, surgery will still help you. But we can't yet predict with any great sort of fidelity what any single person's experience is going to be. And that's where I think building a rapport with people and making sure, trying not to sign them up the second you meet them and having a relationship with them so that there are certainly, it sounds dumb to say, but there's still an art to this. And there is something that we're not capturing yet that we cannot predict who's going to win and who's going to lose, but you can certainly use all of the data generated by this study to help the patient understand what the potential benefits are for them, and then what the potential pitfalls are and the implications of all of those things.
Great. Dr. Glassman?
Yeah, I think that especially this most recent study, the one that Justin wrote that was just in JAMA, I think the piece of information that gives surgeons that they really didn't have previously was that the result you get is likely to hold up, right? Most of the complications were early, most of the revisions were early, and I think we knew that. But most people don't follow their patients for 8 years. And I think that most people couldn't really honestly say to patients, I followed lots and lots of these for 8 and 10 years. They don't know who comes back and who doesn't come back. And I think knowing that you can expect the benefit you get to be reasonably stable is a piece of information that we didn't have before with the level of confidence that this study brings. I think that's probably the most important, patient counseling piece of the long term. It doesn't answer Michael's question, right? It doesn't answer early on who's going to get on the track that wins and who's going to get on the track that, doesn't win. But at least it sort of said to me, you are likely to stay on the track you get on for, 8 years is long-term follow-up for a study, but it's not long-term follow-up for a patient's life necessarily. I guess it depends the age they start. But it's better than what we've had previously.
Yeah, and I think that's what stands out to me so much between this and the sport trial is the lack of real degradation in a lot of the, that you see in a lot of the cohorts of sport. Surgery for adult degenerative scoliosis it's a big ordeal to go through. And yes, you have a high risk of a, needing a revision surgery within the first year. But once you get through this on the other side, you have a durable and meaningful improvement in your quality of life. All right. So one more question. So much of the surgical cohort, being that, we have 8-year follow-up, was before some would say significant advances in our field with respect to understanding of prevention of mechanical complications such as PJK, rod fracture, multi-rod constructs. How might modern techniques impact complication rates if we repeated this study today? Do you think that the techniques have changed enough that the outcomes would be yet even more improved, or do you think we're still pretty much doing it the same way?
I'll take the first run at that. I don't know if Michael may not agree with me. I don't think there's been so much advance as you're describing, right? I think that we've changed our parameters around alignment and focused, a lot of energy in, what we have to modify the formulas to. But I think static alignment is only one piece. And I don't think getting a little better at managing that is really the advance we need. I think that other factors that influence PJK, whether it be physiologic factors like neurologic disease, whether it be understanding sort of alignment in motion. I'm not a big believer that all of a sudden we've solved the tethering problem, right? I think we've had 4 or 5 iterations since the time of this, publication, and not 100% convinced that we're a whole lot further along than we were. So I think actually the techniques now, more rods does prevent some of the rod breakage. It may prevent some of the early, failures. And I think one thing that's kind of interesting is that we didn't see late failures, right? Which is, I think, what you may see with more rods, right? Because if you have a pseudoarthrosis, eventually that's likely, in my mind, to break no matter how many rods. So, I think we've done things that change the trajectory some. I don't actually feel like surgery today is dramatically different than when we did this study. Maybe we're putting our lordosis a little more where it belongs, lower in the lumbar spine. I can't quite remember where the osteotomies were in this cohort. Maybe Michael remembers that. So yes, I think it's reflective of what we do today, because I don't think we've made as much progress as you sort of alluded to. I don't know, Michael, you want to disagree with that?
No, actually, I was kind of thinking of that question in the car today, that the revision rate is not exactly in line with what a lot of people are saying are their revision rates for pseudoarthrosis and PJK at 2 to 5 years. And this just goes back to Dr. Bridwell and Christy Baldus just being like hounds on these people for follow-up. And I don't know if we have really changed revisions for these mechanical complication rates all that much. And if we have, then I think on average we'll do better. But I think the onus is on us now in sort of individual centers and in the study groups to try and be on this like a dog on a bone and get good follow-up, because once we have 50% follow-up at 5 years and 20% at 8 years, you can claim all you want, but it's very hard to say that that's a valid and true conclusion.
Fair enough. Maybe a good way to end our conversation then would be, what unanswered questions remain after this portion of ASLS 1? What's the next study, and is there going to be an ASLS 2?
Dr. Glassman, you want to go?
No, I think there's an ASLS 2. It's going to be with your generation, not my generation. But I think for me, in treating adult deformity, and maybe it's something that AI after some time helps us get at, right? When I make a decision about who to operate on, when to operate on them, it is very commonly related to their neurology. And the deformity is in the way of taking care of their neurology effectively in adult scoliosis. And because it's hard to measure and because MRIs look abnormal in normal people, we've sidestepped that. But I don't think we make another great advance in figuring out who we're going to help, how to help them, who to operate on, until we figure out a way to bring that element, which to me is so core to deciding what I'm going to do for a patient, into the studies that we do.
I think I agree with that, because I think in part what we need now is unmeasured data. We have lots and lots of measured data, and in the ISSG and ESSG, when we combined things, we could not, from my perspective, I don't think we could predict very well any single person's PROMS trajectory, risk of complication. We could predict it slightly better than the flip of a coin, but not that much better, not to a point that is, I would say, clinically relevant. And for me, ASLS2 is multi-pronged. where, and I think you guys had Hills out recently, about
Yeah.
the optimization function of trying to figure out the right surgery for the right patient. And now we have, there's Dr. Bridwell has left the breadcrumbs for us that surgery is on average right, but we need to figure out for whom. And that is going to involve measuring PROMs, but also measuring what their desires are a priori, because cognitive dissonance is very strong. Classically, we talk about it for the neuromuscular scoliosis patients, but cognitive dissonance is the same for adults that undergo this and have 2 revisions. And then we say, how's your pain? And they're like, it's pretty good. And you're like, really? Because you look not so hot. And the only way I can think of to control cognitive dissonance is to make them fill out where I want my 2-year prom to be like before surgery. And understanding patient expectations, understanding patient desires, understanding the physiologic response to surgery, because those are going to be incredibly variable. And we know that that has effects on even smaller surgeries like total hips. Really refining alignment, because that is the one thing under our control. And then other things that we haven't figured out or thought of, and that I think machines will help us analyze. But the next step for me personally is that I want to start really dialing in towards prediction models for the individual so that we can tell who should get it and what they should get.
I think I agree with that. I think the piece of that that's going to help us that we're not far from are measured outcomes rather than patient-reported outcomes. We've just in this last year published some work in the cervical spinal myelopathy with wearables and the ability to metric function. And it not only allowed us to be more granular interpreting what the patient's doing, but it showed us measures that we didn't know were going to be important. It, can look at things like sleep and other things that, are part of their overall response to surgery that we don't generally think about. And I think that we'll get to that for adult deformity, and that won't replace these other things, but I think it'll really augment it. I think it'll also give us a data flow with an amount of data that's much more amenable to these sort of machine learning kind of things, where we're feeding it lots and lots of data points rather than a few data points. And Michael's done stuff in that ballpark. But I think bringing those things together will be a bridge. How soon, we'll see.
Yeah, I mean, I have done enough PROMs research, especially with Leah, that I am a little disenchanted with PROMs, and I like more discrete and objective measures. That's why I like mechanical complications, and I think that I will like wearable data a bit more than how do you feel in this one single moment in time. And I certainly don't like classical test theory stuff anymore. I want to get away from that.
Yeah, awesome. Yeah, as we move into kind of a world of AI and machine learning, we got to remind ourselves, I think, that those technologies are most applicable, as you said, Dr. Glassman, to big data sets like hypertension, diabetes, right? And adult spinal deformity, even when we combine all the national and international centers, it's this tiny little thing.
Brick in the Grand Canyon.
Yeah. So, well, great. Well, Dr. Kelly, Dr. Glassman, thank you so much for joining us and sharing your insights. Your work here has truly shaped the way we care for patients with spinal deformities. And I know our audience, our membership, our listeners are very grateful for your input.
Yeah, I just want to give a final, although we said at the beginning, shout out to Justin Smith, who got this paper into JAMA, a great accomplishment, and he really deserves kudos for that.
Yep. And Liz Yannick. She's the stats wizard behind it. Good to see you guys.
Awesome.
Before you leave us, on behalf of the SRS and the ASLS2 investigators, I would like to give thanks to our industry partners who went above and beyond their typical support of the SRS to provide funding that ensured that this study reached its goal of 8-year follow-up. Thank you to Globus Medical, K2M Stryker Spine, Medtronic, NuVasive, and Zimmer Biomet for your support of this landmark study.